This is Mike Rinaldi, and it's a pleasure to be here. And I'm with an esteemed panel, and we're going to be introducing in a moment, have everybody introduced down the line, and we have our first live case from our own home hospital. And so Mike Reardon's moderating with me, and if everybody could introduce themselves down the line.
SIF Reardon, interventional cardiologist from Penn.
Jeff Southard, UC Davis.
Benita Shaw from NYU.
Matthew Sherwood from Inova Heart and Vascular.
All right, so take it away.
Guys.
What do we have?
Hey guys, how are you? David Rizik from HonorHealth. We've been listening to this enlightening discussion in our ears. Really sounds like a great discussion. It sounds like we have a great panel. I'd like to introduce to my right, Dr. Haider Yassin. Haider is one of our young and up-and-coming stars, and he was actually responsible for picking this case out for us today. I found someone loitering in the hall that you might recognize, Dr. Jim Hermiller. Jim and I have been doing live cases together for a decade, and it is just the most fun thing, and I just always learn so much. So thank you. We have Dr. Robert Burke, our echocardiographer, Dr. Robert Schwartzstein, who is our anesthesiologist, and in the room, we have a great group of cath lab nurses and technicians. We have Brittany in the back, and we have the two ladies who know what I'm going to do before I do it. Okay, Sydney and Tracy. They're wonderful, wonderful to have in these MitraClip cases. So let's get right to the case discussion. Next slide. Haider, he's your patient. Why don't you introduce it to him?
Good morning, everybody. I'm glad to be here. Thank you, Dr. Rizik. Thanks, Dr. Hermiller, and thanks, everybody. Our lovely patient has been a patient of mine for quite some time. He's a 67-year-old gentleman, history of he's got a very complex history of hypertension, dyslipidemia, diabetes, got chronic kidney disease, previous CVA with some significant right residual hemiplegia. And he's been known to have symptomatic mitral valve regurgitation, and then he had a recent admission with florid heart failure. And we thought that this is failing medical therapy, and it was about time for his valve to be repaired. He was declined by the cardiothoracic surgery team because of his comorbidities, his general frailty, and the poor potential for rehab. So we were approached for an edge-to-edge mitral valve repair with percutaneous MitraClip. And
I might add, you made a Herculean effort in stabilizing him, so you did an outstanding job in the management team. Bob Burke, show us what we got there's our images. You can see mitral regurgitation. Next slide. You can just go through these pretty fast there, Chris. Next. Herms, I always like to know the etiology. I think these cases are more successful. There's our quantification. Next. If you don't know the etiology, these things sometimes don't go as well. This isn't pure degenerative, not pure secondary or functional. Seems more like a dilated annulus to me.
Yeah. I mean, I look at a dilated annulus as restriction as well a bit, and I think at least in some of the diagnostic views there may have been a little bit of a cord flailing about, but this is certainly there's not prolapse here.
So Bob Burke. I think everyone in the room, when they saw the imaging we got today, was extraordinarily impressed. Could we go to the echo imaging that Dr. Burke is doing? And Bob, just take us through what you have and the transeptal image that you gave us.
All right, so again, coming to you from our Shea lab here, it's our new Siemens lab. We're pretty fortunate. This has been our platform for the past several years, and it allows us to do some things that you may not see routinely on echo, as far as the use of X-plane, really being able to modify what we're looking at in real time with the TE probe. They've got the Z6MS that allows us to really manipulate the volume data in a way that we can't with a lot of other platforms. Right here, we're starting off at a standard 0 and 90 degrees. We'd already measured with the septal guide to determine that we need to be pretty far posterior in the left atrium. This is a relatively large left atrium. And we want to be mid. As you can see right now in this view, this X-plane view, we're nice and posterior, and we're relatively mid on the right screen. You see the superior vena cava there off to the right. You can see the thin part of the septum. We're pretty well mid. We're definitely not going to be set up for an aorta hugger.
So Bob,
and this is where we're able to go.
Bob, you always advise me Don't be shy about going posterior, but don't be shy, especially with the new XT mitral clip device, to go high. We really shoot for 5 millimeters or 5 centimeters on this, don't we?
Invariably, we're looking for 5 centimeters. That always gives us a better control over the device.
Herms,
and
what
we're not
happened
fighting
here?
for height.
Yeah, so this was very interesting. The first puncture was a little high. It just sort of popped through. And so we pulled that one out and we came back to this. We wanted to be in the mid-septum. Again, we don't want an aortic hugger. And then we just, this is a Bayless system, so you can just see the bubbles from we're burning through here.
And then what you see here is our Bayless ProTrack wire. We use this a lot. I love this wire. And it's sort of, I think Hyder referred to it as a fellow-proof wire or something like that. I think it's a great wire to use for crossing.
Yeah. It was very easy. We had no trouble getting through. We did get some hemodynamics, V-wave around 30 or so. Mean pressure was around 14
These
or 15.
Siemens images are just absolutely terrific, Bob. You really, I mean, Siemens is just a great software, but you do magic with it. This is terrific.
You know, I just think, and it'll be great to hear what the panel says, but, you know, this procedure is every step, you don't skip, you get it right.
Yeah.
Right? So you get this transeptal where you want it, get enough height. We're 5, so we have plenty of length. A little discussion, though, about when we talk about high and distance from the annulus, right? Because sometimes that discussion is difficult. You think high is high in the bicaval. It's not.
Right.
Right? We're talking about really how posterior you are when we're talking about height in that 0 degree. So a little bit of semantics, but
Yeah,
really
it's almost
important.
more the depth that you're giving
Yep.
yourself to work with. You know, height gets confusing as far as aortic versus posterior leaflet.
Okay, so 60 seconds from the panel. Any comments on what we're doing, where we're at? And then Herms, I'm going to be your caddy. You do the case, and I'm going to sit back and chat with the panel while you work. How's that?
That sounds great.
So David, Mike Reardon, I'm still a little confused about the etiology of this. Does this patient have AFib, and how big are the atria?
Bob, why don't you
Well,
talk
the
about...
atria are huge on this patient, and he does not have atrial fibrillation. He's actually in sinus rhythm. In spite of his hypertension, renal failure, and other comorbidities, he's maintained normal sinus rhythm. He definitely has a very elevated left atrial pressure, and we actually see this on the mitral inflow. You can see that the mean gradient here is actually quite low. It's 1.6 millimeter mercury. We do have a little B bump there, just saying that the left atrial pressure is elevated. Not much of a contribution to filling with the atrial contraction, as you can see by a relatively diminutive A wave there. His function is actually about 51 is what we get on the LV analysis software. So this is actually looking at 3D volume of the left ventricle, and he averages around 51, 52%. That's what we've had on transthoracic. Now, in the setting of his severe mitral regurgitation, that is significantly decreased and does contribute to his heart failure. So this is still not a normal function by any stretch of the imagination. He's definitely hypertrophied, nice thick ventricle, what you'd expect with his renal failure.
So David, with the really big atria, does that change your approach at all?
Yeah, Herms, why don't you field that?
Not really, Mike, for me. I just, it gives me room to get the device in maybe a little bit easier. And, you know, sometimes you can get too much height occasionally because you got such big biatrial enlargement. But I think as long as you stick to the rules and you've got distance and you're sort of in the mid-septum on bicaval, you're fine.
I think we live in big atria. I think they all have biatrial enlargement. By the time we get to these patients, the secondary MR certainly have oftentimes have biatrial enlargement. I think that's our norm. To say the atria big in this guy with mitral regurgitation, it's almost a redundant statement to me.
Yeah.
So I think you're probably going to have a discussion about how to pick what clip, because there are now new flavors of clips. And I think it's important for the audience that thinks about these procedures to remember to always look when you're screening for these patients at the size of the annulus and what the gradient is, and that helps in decision-making about clip choices as well.
I will tell you, the clip choice for me has been easier. We have the new XT, the Mitral Clip XT, which has 3 millimeters more grasping length on each arm. for a total of 22. And I will tell you, I think, in the COAP trial, they used 1.7 clips per case. I will bet you if it was the XT that was available and they were using that routinely, I think that might have been 1.1 or 1.2 because we clearly use fewer numbers of clips per case with the longer grasping length. Do you agree with that?
Yeah. Mike, great question. I think for the XTR, clearly these leaflets are long enough, right?
Yeah.
Geez, almost 2 probably. So, we're going to be right down the middle. We're not out into the commissures. So it's a perfect XTR. The gradient was 1. It's a big valve area.
Well, in the interest of time, because we have something going on next door that might be of interest as well. Dr. Alok Sharma and Dr. Bimal Patel, you have some surprise that I don't know about. So why don't we, Bob, we have plenty of circumference there as you're showing.
That was actually just using 3D multi-plane extraction and showing that the area of the valve was around 6.2 centimeters squared. So it's well over the 4 centimeters squared that we typically look for to minimize the risk of mitral stenosis.
So Bob, would you go to
technology.
X-plane right now? Okay. So Mike Rinaldi, are you there?
I'm here.
Feel free to chat and talk while Herms works.
Yeah, so we brought the clip in, Mike, really easily. I mean, this all took about 5 minutes to do here. So, and we've aligned it. It's interesting. We were 90 degrees out of phase with respect to the rotation. And you could have picked either to go counterclockwise or counter. And I picked counter because, for the XTR system NTR, as you come rotationally, it's almost like you're moving your guide in the same fashion. So I came counterclock, which means I clocked it, which gave me more height. So just sort of kind of finesse point, I think.
And I think just like working hard to get the right transeptal puncture, it makes the case easier. One of the things I think we're all learning with the XT is that arm orientation becomes even more important. Even slightly off arm orientation can lead to pleating and new jets or gradients so I think it's just really important to focus on that.
Yeah, and Bob, could you just give us a 3D? Let's just look at it.
Sure.
Just because we've been sitting a while, just make sure that we're lined up.
Dr. Schwartzstein, just keep your eye on the ACT, please.
Yeah, I think with the
Optimize this a little
XT,
bit.
every time you make a different move, I think it's helpful to go back to the 3D and make sure you're totally aligned for the reasons that you stated, Mike, so that you're not off, you're not grabbing stuff that you don't want to and creating a more difficult problem to deal with.
The really wonderful thing about this case is the jet's down the middle, the posterior leaflet's good and long, there's no calcification of the cords, so this is a really great case for this procedure.
Yeah, and how about we just hold respiration? There's a lot of respiratory movement here.
Sure moves lateral, doesn't it? Yeah, there we go.
I want to just push it in. This sort of warmed up as we were sitting. I think that looks good, huh?
So for those that don't do MitraClip, pushing the whole system in, moves lateral, pulling the system back, moves medial, or we have a medial and lateral knob.
So I think we're pretty good there.
Bob, go to X-plane, please.
Yep.
Almost looks like
And while they're positioning, one of the things you can do to help keep the clip down the center or in whatever position you want is have very low tidal volumes as opposed to just a prolonged breath hold, and that's tolerated even better.
That's a great point. So I went to 60. I've got a little bit of clip turn here.
Yep, we rotated on that one.
And I bet I got, let me just come a little bit anterior. There we go.
Okay, good. You're going to go 3D, Bob?
Yep, I'll bring you back on 3D. And looks like we rotate a little bit. We're still looking pretty good as far as overall positioning.
Mike, can you see both echo and fluoro where you're at? Yeah, we rotate.
We can see it
So
perfectly.
we definitely countered as we went in.
So what Dr. Hermiller is doing, for those who don't MitraClip, he's taking some of the tension off with just kind of rotating it back and forth, and he's turning clockwise, and now he's opening up his clip a little bit, opening up the arms.
So that looks pretty good.
Still maybe a little bit more countered than you want. You're sort of at an 11 and 5 orientation right now.
Okay. Why don't we go? Can I just see an X-plane? I'm going to come up and grab
Absolutely.
these things.
So now this has, for those again who don't do this, there's grippers. They have little hooks on them, the grippers. And when we're ready, when Dr. Hermiller tells me, we're going to drop the gripper, and then we're going to close the clip. So he's rotating the whole thing posteriorly to try and get that posterior leaflet better. Oh, look at you. Oh, that thing's folding
Drop
over.
the posterior leaflet there, but looking good on the anterior leaflet.
I just
It don't-
don't know
Sort
that
of rolling
posterior.
over on that posterior.
Yeah, it almost looks like the
land.
posterior leaflet's folding backward and might have a
I
cord.
agree, Mike. I think we need to close these a little bit.
Orientation looks pretty good on fluoro there. There you go.
It kind of rolls it up, doesn't it? Let's see if I can come down and get it a little better.
I like anterior.
Yeah. I want to get that posterior. I'm really getting it. I might have to do a little positive to get this thing.
Fell off there.
Yeah.
I think our rotation, we probably ended up losing orientation there.
All right. Let's see here.
You want me to go back to a 3D?
Yeah, that'd be great. Let's just kind of see where we are. You know, there's a lot of restriction in that posterior leaflet.
And the great thing about this procedure is it's so controlled, you can just take the time you need to do to get it right.
So again, we're still countered compared to where we originally wanted to be.
You like that?
Cut the
Bob?
gain down so that we can actually see the clip arms better now that we're into the ventricle.
You
So
like
that's looking better. You can see in the middle pane here on the left, the green pane, that's going to give you a sense of your outflow tract view. And that will give you the best idea of where we're going to be orienting regarding the arms and the leaflets.
Do you think I've drifted medially, or we're still down the middle there, Bob?
We need it to be just a hair medial on A2, P2. So I think that's pretty much where we want it to be.
All right.
There's still some variation with respiration.
Yeah.
We're not going to get away from that one. It looks like that posterior leaflet, if we could be just a little bit more clocked, we might get a better purchase on it.
Okay. Got it.
And that did change
That's
our
it,
orientation
that's it.
a little bit. That's looking
That's
better.
perfect. I like that.
All right.
And I'll go back to a biplane for you here.
I'm liking that a little bit better.
Let's just see if I can get this done. There's sort of posterior.
Maybe open up a little bit. The clip.
is opened.
You know, I don't like the way that anterior arm
It
looks.
keeps falling off, yeah.
Right?
So one of the things to think about when you're ping-ponging between leaflets, when you can grab one but not the other, is that the arm orientation is
There
off,
you
even
go.
though it seems like it isn't.
That's looking better. We're tapping nicely.
That's beautiful.
Tell me when, Herms.
You're under the posterior nicely there. It's not rolling on you. That's just laying out pretty nicely.
Yeah.
There we go. Yes?
Drop
Herms,
Yeah, I just
No,
don't.
we're not supposed to.
You know, why don't you just look, see what those.
Anterior is laid out beautifully
Yeah,
right
let's see
there.
what the rotation looks like. I just, at least fluoroscopically,
I think he's going to look funky fluoroscopically.
I
Just think our orientation on him and the way that his heart is laid out is not entirely normal.
So this is one of the, as Mike Rinaldi was saying, really one of the beauties of this procedure. It's controlled.
Actually, that doesn't look bad, does it?
Yeah, that orientation looks very good. It's a very controlled procedure. You can keep going back and forth, in and out, until you know that you have everything. Little
Yeah.
counter, maybe?
Might be able to handle a little more counter. It looks like we came more
There we go.
clock than we
Yeah,
needed to.
that's nice.
Again, we're seeing that anterior clip arm much better as you did that. You
Yeah,
see
yeah,
that
yeah,
came
yeah,
in
yeah. That looks good.
nicely
That looks good.
in that green panel.
Yeah.
in
You want to
the
go
Y
back to
plane.
X-plane now?
Yep.
And so you can definitely make small adjustments in the ventricle. You can't spin it because what you can't see are all the cords, but you can feel them.
I like that. You like that, Mike?
That looks great. You can now see the leaflets right on top of the arms, and that's
Yeah.
the best way to
Drop,
predict you're
drop.
not going to
Looking
have a single
good.
leaflet detachment.
Clip arms down, or grippers down. I'm going
You
to
got
close
the
my clip arm a
grippers
little bit.
dancing a little bit there. That's nice.
That's good. And let's...
Pluralize,
I
pluralize.
took a little tension off.
And so that's another key move, especially with XT, is as you close the clip, you advance the clip a little bit into the ventricle and take some of the tension off. And that, if you're pulled way up into the atrium and you clamp down that clip, you could potentially perforate a leaflet. So you have to take a little tension off, pushing it into the
You can
ventricle.
see you're
slightly.
wrapped over the anterior leaflet there, how it's draping in.
So Bob, do me a favor, splash some color on that so we can see what we got.
Okay. And we still have some color. Again, we're hardly closed right now.
We're hardly closed. So now we're going to lock the clip. Bob, do you want me to lock down a little bit more?
I'll close it down some, yep.
I think it looks better.
I think another teaching point that we've learned, especially with XT, is to not crank it all the way until it won't close anymore, but just to close it almost perfect. But if you over-tension it, there's more risk of damage to the leaflets.
Okay, so now what we're going to do, this is a key part of the procedure. What we do is we have Dr. Burke do an interrogation. He's going to look at the pulmonary flow, hemodynamics, and flow pattern. He's going to look at what gradient we have. We don't want to leave a gradient of greater than 5 because trading mitral regurgitation for mitral stenosis is not what you want to do. And then finally, he will look at the severity of MR. He'll try and find a PISA and these sorts of things. Let me ask a question. So the gradient is 3.1 right now, Bob? Is that what you
Yep.
have?
Great.
Okay, now, why don't we do this? Why don't we refine what we're doing here, Herms? Do you mind? Hey, guys. All
We're
right,
back.
so Herms, why don't you discuss what we did
Yeah.
when we went off camera?
Yeah, so, and Bob can show this. We had mild sort of MR, and we weren't quite delighted with how much posterior leaflet we had in there. And so I basically released the grasp we had and then went a little more posterior and got much more posterior leaflet. And then, we ended up with very trivial leak at all. And,
Bob, what are you showing right there?
So this is the analogous view to an LV outflow tract view or a parasternal long axis view. And what we're seeing here is, let me just get my cursor back up. We've got the clip here. We've got anterior leaflet and posterior leaflet. The aortic valve is up here. LV is here. LA is here. We're seeing a tissue bridge that's very nice, and we're seeing it coming through nicely through the anterior leaflet and the posterior leaflet feeding into the clip.
So you're confident of these grasps, that these are going to be durable grasps, correct?
Oh yeah, our initial measurement of residual posterior leaflet was a little bit over 6 millimeters. We're down to 4 millimeters now on repeat measurements, so we gained a couple extra millimeters of grasp of the posterior leaflet.
Great imaging, Bob. Look at that.
and we started
midpoint.
with what, 1.4?
Yeah, exactly.
So we almost got 10 millimeters in that
Right,
thing.
right, right. Okay, so Bob, I'm going to ask you 3 questions because I always ask you these 3 questions. First, did we reduce the severity of MR at least 2 grades?
Absolutely. We went from severe, which was quantitatively greater than 0.5 centimeters squared, and we're down to now really pretty much trivial residual
Okay.
mitral regurgitation.
That's 1. Did we didn't trade a gradient of less than 5 for a gradient of more than 5, correct?
Correct. We're at a gradient of 3.6 millimeters mercury here, and
then-
again with normal heart rate.
Okay, with normal, and then the pulmonary hemodynamics?
And this is the left-sided pulmonary vein, which was reversed and is now basically normalized with good systolic flow.
I say we motion for adjournment, and why don't we do this? We don't need to show releasing the clip, but I think we got what we came for, Herms.
Yeah, oh,
I
yeah.
think
No, this is a great result. And I think, again, we're very methodical every step. And then 2, releasing this to get an ideal grasp, right?
Absolutely.
It was a good one. In the old days, I'd take it for sure.
Right.
But now, You know, we want to go for perfection.
You happy?
Happy?
You think your patient's going to do better?
He's probably going to feel a lot better.
Okay, we're going to go back next door. Thank you very much. Great case, and working with this guy is always such a pleasure. I always learn so much from him. It's terrific.